Welcome to another module synopsis. Today we're going to do Module 5. Look over these Module 5 objectives. Make sure you feel like you've met each one. If not, go back through the material and see if that helps you kind of put things together. Now that you've looked them over, think about it. Which module objective made you think the most critically? Okay, let's talk about psychosis. Approximately 3% of the people in the United States experience psychosis at some point in their lives. About 100,000 adolescents and young adults in the U.S. experience their first episode of psychosis each year. The term psychosis describes a condition where there's a loss of contact with reality. When a person experiences psychosis, their thoughts and perceptions are disturbed, and the individual has difficulty understanding what's real and what's not real. Symptoms of psychosis include delusions and hallucinations, where the client is hearing, experiencing, or sensing things that aren't real. Psychosis can be a symptom of various mental illnesses like schizophrenia, bipolar disorder, severe depression, or severe anxiety, but there are also potential causes. Other than that, sleep deprivation, medical conditions such as hyperglycemia, hyperthyroidism, side effects of some prescription medications, and use of alcohol or other drugs can cause psychotic symptoms. Early signs of psychosis: dropping grades, new trouble thinking clearly or concentrating, suspiciousness, paranoia, withdrawing socially, unusual, bizarre new ideas, strange feelings or having no feelings at all, decline in self-care or personal hygiene, difficulty telling reality from fantasy, confused speech or trouble communicating. Symptoms of a psychotic episode include delusions, hallucinations, disorganized speech, or grossly disorganized or catatonic behavior. Treatment for psychosis is treating the cause. For example, if the psychosis is caused by a medical condition or effect of a medication or withdrawal, fixing the underlying cause will treat the psychosis. However, if the psychosis is a symptom of a mental illness, the treatment would typically include a combination of antipsychotics and psychosocial therapies. So, in other words, for psychosis, treat the cause, treat the disorder. What about delirium? So, psychosis caused by a medical issue is often referred to as delirium. The two terms, however, are not interchangeable. Delirium is a mental state in which the client becomes temporarily confused, disoriented, and not able to think or remember clearly. The big difference here is delirium starts suddenly. It can indicate the onset of a life-threatening medical condition. Delirium resolves as soon as the underlying condition is effectively treated. Some common causes: dehydration and electrolyte imbalance, dementia, hospitalization, especially in the intensive care unit, intoxication or withdrawal from alcohol or drugs, kidney or liver failure, medications like sedatives, opioids, anesthesia, antihistamines, anticholinergics, antidepressants, antipsychotics, or anticonvulsants, metabolic disorders such as diabetic ketoacidosis, serious infections such as urinary tract infections, pneumonia or influenza, severe pain, and sleep deprivation. Symptoms of delirium start suddenly over a few hours or a few days, and they often come and go. You can have changes in alertness, in levels of consciousness, confusion, disorganized thinking, disrupted sleep, emotional changes, hallucinations and delusions, incontinence, and memory problems, especially with the short-term memory, trouble concentrating. The symptoms of delirium can often be managed with making sure the room is quiet and well lit, keep clocks and calendars within view, have family members visit, ensure the client is wearing their hearing aids and glasses, allow for uninterrupted sleep, getting patients up and out of bed, controlling pain, and administering prescribed medications. Just make sure administer medications with caution because oversedation can worsen delirium. Avoid the use of restraints. Schizophrenia is on a spectrum of psychotic disorders. It's a serious mental illness that affects how a person thinks, feels, and behaves. It also affects the person's ability to recognize their symptoms as problematic, which is referred to as lack of insight. So schizophrenia has a lot of the same signs and symptoms of delirium, but the difference is these things start gradually. Schizophrenia is most often diagnosed in the teen years to early 30s, and it emerges earlier in males than females. The diagnosis of schizophrenia usually follows the first episode of psychosis when the individual first displays symptoms of schizophrenia. Gradual changes in thinking, mood, and social functioning often start earlier, sometimes in the early teens. So for symptoms, there are positive symptoms, negative symptoms, and cognitive symptoms. Positive symptoms mean something is present. hallucinations, delusions, thought disorders, disorganized speech, and alterations in behavior. Negative symptoms mean something is lacking. So that's reduced motivation, difficulty planning, beginning or sustaining activities, diminished feeling, or flat affect, sometimes even reduced speech. Cognitive symptoms that refer to problems with attention, concentration, and memory. These can include difficulty processing information to make decisions, problems using information immediately after learning it, or trouble focusing and paying attention. Additionally, for a significant portion of the time, the client's level of physical functioning in one or more areas like work or interpersonal relationships or even self-care is significantly below their prior level of functioning. Risk factors for schizophrenia include genetics, environment, brain structure, and function. In genetics, it's known to run in families, and that's been proven through research. Environment. Scientists think that interactions between genetic risk and aspects of an individual environment play a role. So, things that this could include are adverse childhood experiences or exposure to viruses or nutritional problems before birth. When it comes to brain structure and function, scientists think that differences in brain structure, function, and interactions among neurotransmitters may contribute to the development of schizophrenia. For example, differences in the volumes of specific components of the brain, the manner in which regions of the brain are connected and work together, and neurotransmitters such as dopamine are found in people with schizophrenia. Early treatment of psychosis increases the chance of successful remission. Treatments focus on managing symptoms and solving problems related to day-to-day functioning. Antipsychotic medications is one of the ways that schizophrenia is treated. It reduces the intensity and frequency of psychotic symptoms by inhibiting dopamine receptors. Certain symptoms of psychosis, such as feeling agitated and having hallucinations, can resolve within days of starting an antipsychotic medication. Symptoms like delusions usually resolve within a few weeks, but the full effects of the medication may not be seen for up to 6 weeks. So, we need to get into some of the side effects of antipsychotics in the context of psychosis and schizophrenia, because when you're caring for a client with these disorders and they're on these antipsychotics, the impacts of the antipsychotic medicine can be life-altering. Not to mention the side effects themselves can stop people from taking their medication. So there's first generation or typical antipsychotics and second generation, which are atypical antipsychotics. They both treat positive and negative symptoms, and we'll get into the differences in the two when we talk about psychopharmacology. There's also clozapine. That is for patients with treatment-resistant schizophrenia, and it's a specific type of antipsychotic medication. It has a really dangerous potential side effect called agranulocytosis, which is an extremely low white blood cell count. It also has strong anticholinergic, sedative, cardiac, and hypotensive properties. It also has frequent drug-to-drug interactions. So, common side effects for both first and second gen antipsychotics are anticholinergic symptoms like dry mouth, constipation, blurred vision, or urinary retention. Drowsiness, dizziness, restlessness, weight gain, nausea, vomiting. Extrapyramidal side effects like akathisia, which is the psychomotor restlessness, rigidity or bradykinesia, which is slowed movements, tremor, dystonia, which is involuntary contraction of the muscle extremities in the face, neck, abdomen, pelvis, larynx, in either sustained or intermittent patterns, are all side effects of first generation antipsychotics. An acute dystonic reaction affecting the larynx can be a medical emergency. Extrapyramidal symptoms usually resolve dramatically within 10 to 30 minutes of the administration of parenteral anticholinergics such as diphenhydramine, which is Benadryl, and benztropine. Tardive dyskinesia is a syndrome of movement disorders that can occur in clients taking first-generation antipsychotics. Symptoms to look for: smacking and puckering of lips, eye blinking, grimacing, twitching. Tardive dyskinesia persists for at least a month and can last up to several years even if the medication has been discontinued. The primary treatment for tardive dyskinesia is discontinuing the first-generation antipsychotic, but also includes the addition of other medications. A rare but fatal adverse effect called neuroleptic malignant syndrome can happen in people taking antipsychotics. It takes days to weeks to develop, but takes less than 2 weeks to resolve with treatment. Keep an eye out for an increase in temperature, severe muscular rigidity, confusion, agitation, hyperreflexia, elevation in white blood cell count, elevated creatinine phosphokinase, elevated liver enzymes, myoglobinuria, and acute renal failure. The antipsychotic should be immediately discontinued when there are signs of neuroleptic malignant syndrome. Dantrolene is typically prescribed for treatment. Patient teaching and education is of the utmost importance when people are taking antipsychotics. They should be advised to contact their provider if they have any involuntary or uncontrollable muscle movements. They should also be warned never to suddenly stop taking the medication. Abrupt withdrawal can cause dizziness, nausea, vomiting, and uncontrolled movements of the mouth, tongue, and jaw. When people stop taking their medications, they can relapse. And once they experience relapse, sometimes that leads directly to hospitalization. A relapse is when their psychosis symptoms come back or get worse. It typically occurs when people stop taking their prescribed medication. Most people with schizophrenia have to stay on their antipsychotic medication continuously for months or years for their mental wellness. Psychosocial treatments. Cognitive behavioral therapy, behavioral skills training, supportive employment, and cognitive remediation interventions are types of psychosocial treatments that can help address the negative and cognitive symptoms of schizophrenia. A combination of therapies and antipsychotic medicine is the most common. Make sure you're providing family education and support. If families and friends understand the symptoms and the treatment time frame, it helps them experience less distress and they can be more supportive to the patient. Also, coordinated specialty care. That's a general term used to describe recovery-oriented treatment programs for people with first episode psychosis and early stage schizophrenia. There is a team of health professionals and specialists that include psychotherapy, medication management, case management, employment and education-centered and family-centered support systems. This approach helps them make treatment decisions. Compared to typical care for early psychosis, coordinated specialty care is much more effective at reducing symptoms, improving quality of life, and increasing involvement in work or school. The goal is to link the individual with a coordinated specialty care team as soon as possible after the psychotic symptoms begin. Lastly, assertive community treatment is designed for individuals with schizophrenia who are at risk for repeated hospitalizations and homelessness. Research has demonstrated a prevalence of psychosis as high as 21% among the homeless population living on the street. ACT is based on a multidisciplinary team approach, including a medication prescriber, a shared caseload among team members, and direct service provision by team members, high frequency of patient contact, low patient to staff ratios, and one-to-one outreach to patients in the community. It's been shown to reduce hospitalizations and homelessness among individuals with schizophrenia. Okay, let's apply the nursing process in a quick chat. Assessment. It involves interviewing the client, observing verbal and nonverbal behaviors, and completing a mental status examination and a psychosocial assessment. You want to look at their medical diagnosis, their diagnostic and lab work, and then we can move on to looking at nursing diagnoses. So, common nursing diagnoses related to schizophrenia. Risk for suicide. Definition: susceptible to self-inflicted, life-threatening injury. Defining characteristic: reports desire to die, threats of killing self, hopelessness, social isolation. Another nursing diagnosis: ineffective coping. The definition is a pattern of invalid appraisal of stressors with cognitive and or behavioral efforts that fail to manage demands related to well-being. Selected defining characteristics include alteration in concentration, alteration in sleep pattern, inability to meet basic needs, ineffective coping strategies, insufficient goal-directed behavior, and risk-taking behavior. Another diagnosis, nursing diagnosis, self-neglect. Definition: a constellation of culturally framed behaviors involving one or more self-care activities in which there is a failure to maintain a socially acceptable standard of health and well-being. Selected defining characteristics: insufficient personal hygiene, insufficient environmental hygiene, and non-adherence to health activity. So, outcomes identification. Outcomes should be consistent with the recovery model and emphasize hope, resilience, living and fulfilling a productive life, and recovery from illness. Expected outcomes are identified based on the client's current phase of their illness. Are they in acute phase, stabilization phase, or maintenance phase? If they're in an acute phase, the overall goal for the schizophrenic patient is safety and stabilization. Stabilization period, the goals are focus on an understanding of the illness and the prescribed treatment plan, as well as controlling and or coping with the symptoms using an optimal medication and psychosocial treatment regimen. If they are in the maintenance phase, goals include focusing on maintaining and increasing symptom control and optimal functioning. Factors include treatment adherence, increasing independence, and a satisfactory quality of life. An example of an expected outcome during the maintenance phase would be the client will identify advantages for taking medications by the end of week 2. When you're planning interventions, hospitalization is indicated during the acute phase. During stabilization and maintenance phase, planning focuses on education, support, and skills training for the client and family. It also addresses how and where these needs can be met within the community. As explained previously, relapse prevention efforts are vital. Each relapse can increase residual dysfunction and deterioration and contribute to despair, hopelessness, and suicide risk. Moving on to implementation. During the acute phase of schizophrenia, hospitalization provides safety, structure, and support. The client's ability to recognize their mental illness is going to be an issue in this phase. Sometimes court-ordered hospitalization is required. So, nursing interventions focus on providing safety, promoting hygiene and nutrition, improving socialization, encouraging hope and self-esteem, preventing falls, using specific therapeutic techniques, addressing physiological needs, and implementing collaborative interventions. Make sure you're providing safety. Make sure you're promoting hygiene and nutrition. Improve their socialization. Encourage hope and self-esteem. Prevent falls. Use therapeutic techniques for delusions and hallucinations. So, helping clients who are experiencing delusions, they feel very real to the client, and they can be frightening. Acknowledge and accept the client's experience and feelings resulting from the delusion while conveying empathy. Avoid questioning the delusion, because until the client's ability to test reality improves, trying to prove a delusion incorrect can intensify it and cause the client to view staff as people who cannot be trusted. Helping somebody who is experiencing hallucinations. Those are also very real to the person experiencing them and can be distracting during their interactions with others. They can be supportive or they can be terrifying. They can be faint or they can be loud. They can be episodic or they can be constant. For example, listen to simulations of auditory hallucinations. The nurse should focus on understanding the client's experience and responding to convey empathy. Command hallucinations, suicidal ideation, or homicidal ideation requires safety measures as previously discussed. So, what surprised you the most in learning about schizophrenia and other psychotic disorders? Well done, everybody, and keep up the good work.